Okay, today we will discuss three topics. We will discuss thalassemia with pregnancy, sickle cell disease with pregnancy, and at last we will discuss breast cancer with pregnancy if there is time for breast cancer. We will start at first by thalassemia and sickle cell disease. We call them hemoglobinopathies. They are disorders of hemoglobin, and we will understand them well today, inshallah. At first, what is the structure of hemoglobin? Hemoglobin consists of heme and globin. Heme, this is iron. Globin, this is protein. And this protein consists of four molecules. Four molecules. As you see here, they are colored. There are four molecules. These four molecules, two of them are called alpha chain. So this is alpha chain and this is alpha chain. So any human being, either an adult or fetus, should have two alpha chain subunits in the globin protein of the hemoglobin inside the RBCs. So we have two alpha chain and we have two other chains. These other two chains may be beta, maybe gamma, maybe delta, according to is it an embryo or an adult. Anyway, we have to understand that our globin consists of four chains. Two of them are alpha chains. Two of them are non-alpha chains. For example, in the embryo, it's gamma chain. So the embryo, its hemoglobin contains two alpha and two gamma subunits. And it's not accepted that a living body doesn't have alpha chain. If there is a fetus which completely doesn't have alpha chain, this fetus will die from anemic heart failure and hydrops fetalis. But if there is no gamma chain, delta chain may be present, beta chain may be present, but anyway, there is no substitute for alpha subunits. There is no living without two alpha subunits. It's not accepted that there is complete absence of alpha subunit. This is not accepted. So again, this is a globin. There are four chains, two of them alpha. If we are talking about adult, so two alpha and two beta. Each one of them has one iron molecule. Each molecule of them is capable of carrying one atom of oxygen. So we have four chairs to carry oxygen in the hemoglobin molecule because there are four iron molecules. As you see here, this is birth. So here we are talking about embryo or fetus, and here what is after birth. Always there should be two alpha subunits. As you see, if you are talking about adult, child, infant, embryo, alpha subunits should be present. There may be partial absence, okay, but complete absence, no. There is no life without complete absence of alpha subunits. In the fetus, in addition to two alpha subunits, there are two gamma subunits. I memorize it by gamma is present in janin. Gamma is present in janin. So the fetus contains two alpha and two gamma. After delivery, there is decrease in the level of gamma chain and becomes replaced by beta chain and two beta chains and the two alpha chains. This is the adult hemoglobin. And as you see, gamma globin is decreasing with time. At about 2 years, you can say that very minimal gamma chain and most hemoglobin is 2 alpha and 2 beta. While in the fetus, 2 alpha plus 2 gamma. That's why after birth, there is destruction in the fetal RBCs after birth. This is one of the causes responsible for neonatal jaundice, that there is destruction of fetal RBCs. So gradually, we are replacing fetal RBCs to become adult RBCs containing beta subunits. Somebody has a question? So again, in the fetus, we have 2 alpha and 2 gamma subunits, gamma ganin. In adult, most of adult hemoglobin contains 2 alpha plus 2 beta. And there is another type of adult hemoglobin. It's called adult hemoglobin type 2, which is present in minimal concentrations. It contains 2 alpha and 2 delta. Again and again, as you see, alpha subunit is very, very important. So we have 2 types of adult hemoglobin, and there is fetal hemoglobin, which contains gamma subunits. If you are talking about adult person, 90% of the hemoglobin is adult hemoglobin type 1. Less than 5% adult hemoglobin type 2, and less than 2% fetal hemoglobin. And there is another form of hemoglobin, it's called glycosylated hemoglobin, hemoglobin A1C. And we use hemoglobin A1C to identify the status of diabetes. Was it controlled within the previous 3 months or not? Okay, who is raising hand? Somebody is raising hand? Please raise hand. You have a button, it's called raise. Dr. Najla, you muted yourself, unmute yourself. Okay, Dr. Faiza?
Yes, sir.
Dr. Faiza, please can you tell me what is the significance of hemoglobin A1C to identify the status of chronic diabetes control during pregnancy?
HbA1c tells us the pre-pregnancy control before, diabetic control before 3 months.
I will add
in the last 3 months.
I will add an information to you. Okay. During pregnancy, we don't use hemoglobin A1C to monitor glycemic control. We use fructosamine.
Yes, but in chronic hypertension.
Sorry. I am talking about glycemic control in cases receiving. Your answer is right. I'm sorry. I am talking about glycemic control in patients receiving blood transfusion. Can we use hemoglobin A1C? No, we use fructosamine in patients receiving blood transfusion. Okay, because hemoglobin A1C, the patient is already receiving a blood transfusion. So this is not her own hemoglobin. So you can't rely upon hemoglobin A1C to monitor glycemic control in diabetic patients with repeated blood transfusion. Okay, is it clear, Dr. Faiza? Your answer is right.
Yes.
And in cases with blood transfusion, you can rely upon hemoglobin A1C. You can use hemoglobin A1, you can use fructosamine, and we will explain this point today when we talk about thalassemia and sickle cell disease. Thanks, Dr. Faiza. So this is the hemoglobin composition in adult person. Most of them, hemoglobin A1, some less than 5% hemoglobin adult type 2, less than 2% fetal hemoglobin, and hemoglobin A1C, we can use it for monitoring of diabetes during but don't use it in patient who is receiving repeated blood transfusion, as in cases with thalassemia and sickle cell disease. So we know now that 2 alpha subunits and 2 beta subunits should be present in the adult person. There are disorders of alpha subunit and there are disorders of beta subunit. That's why we have alpha-thalassemia and beta-thalassemia. Alpha-thalassemia, disorders of alpha chains, and we have two chains, as you know. Beta-thalassemia is disorders or absence, either complete or partial, of beta chains. This thalassemia is autosomal recessive disorder. The meaning of autosomal recessive, that the 2 alleles should be affected to have the character. If there is 1 allele affected, this is carrier, not patient. To be a patient, to be symptomatic, affection of the 2 alleles should be present. So it's an autosomal recessive. The severity is related to number of affected genes. And we will know that we have alpha chain and we have beta chain. Alpha chain, we have 2 alpha chains. Beta chains, we have 2 beta chains. Alpha chain is genetically coded by chromosome number 16, while beta chains are encoded by chromosome number 11. How many alleles encoding how many genes encoding for alpha subunits? We have 4 genes. How many genes encoding for beta subunit? We have 2 genes. So if there is 1 gene is affected, if all 4 genes are present, alpha subunits will be normal and no problem in alpha subunits. There may be absence of 1 gene, 2 genes, 3 genes, 4 genes. Any one of them can occur. If there is absence of the 4 genes, there is no alpha subunit now, and this is incompatible with life. This fetus will die of hydrops fetalis or will die very soon after delivery, because there is no life without alpha subunits. In beta subunit, if 2 genes are present, this is normal person. There may be absence of 1 gene, this is carrier. There may be absence of 2 genes, this is called beta-thalassemia major, or maybe absence of 1 gene and partial absence of the second one. So we have intermediate. That one is absent and the other one is partially functioning. So here may be normal, absent 1 gene, 2 gene, 3 gene, 4 gene. So we have 5 types. We have minor, major, intermediate. We have 3 types. So it's according to the number of affected genes. The problem is these malformed RBCs, which has defective alpha subunit or beta subunit, of course, their lifespan is decreased. So we have increased hemolysis. These destructed RBCs, this is the cause of anemia. These destructed RBCs, they contain iron. So after destruction, their iron will lead to iron overload. So this iron will be precipitated in all body organs. in the brain, hypothalamus, pituitary, thyroid, pancreas. So we will find affection of pituitary glands. You may find diabetes. You may find hypogonadotrophic hypogonadism and infertility. This iron also will lead to iron intoxication of the liver, iron intoxication of the heart, all body organs. So it's not logic to give iron for this woman. Already she has iron toxicity. She is complaining from excess iron in her body. So it's not logic to give iron for such women. After this anemia, there should be compensation by erythropoiesis. So we have hepatosplenomegaly due to increased erythropoiesis as a trial to compensate, and also destruction of these malformed RBCs. Again, alpha chain, we have 4 genes on chromosome 16. Beta chain, we have 2 genes on chromosome number 11. Which type of anemia is it? It's microcytic hypochromic. So hemoglobin level will be decreased. Mean corpuscular volume decreased. Mean corpuscular hemoglobin concentration also decreased. It's microcytic hypochromic anemia. What is the differential diagnosis of microcytic hypochromic anemia? We will say that this is anemia if hemoglobin is decreased. What is the normal hemoglobin level during pregnancy? Somebody knows?
क्या करना है?
Okay.
11.
If somebody knows the answer, you can unmute yourself now. What is the
11.
during pregnancy?
11 at the beginning and then 10.5 later.
When, please?
11 initially
Yes.
till first trimester,
Yeah.
and then later or until 28 weeks, and later it is 10.5.
And after delivery?
After delivery, 10.
And in non-pregnant?
In a non-pregnant, it would be 12.
12. Thank you. You're right. So in non-pregnant woman, hemoglobin normally above 12. During first trimester, we can diagnose anemia if hemoglobin is less than 11. At 28 weeks, again we evaluate hemoglobin. If it's less than 10.5, this is anemia, so we can give iron. And after delivery, normal level more than 10. So this is a definition of anemia in non-pregnant, pregnant, and postpartum women. We say that thalassemia is microcytic hypochromic. The differential diagnosis of microcytic hypochromic, number 1, iron deficiency. It's the commonest one, iron deficiency. Number 2, thalassemia. Number 3, sideroblastic anemia. So iron deficiency anemia is the commonest. So in any woman complaining from microcytic hypochromic anemia, we start management at first by giving iron supplementation. And after 2 weeks, we reassess hemoglobin level, expecting that there is improvement. If there is no improvement, we can suspect thalassemia. After confirmation that the woman was adherent to the treatment. So we can now do serum ferritin. If serum ferritin is low, this is iron deficiency anemia. So we can start giving parenteral iron and to see why iron was not absorbed. If serum ferritin is normal, this is not iron deficiency anemia. In iron deficiency anemia, if we do serum ferritin, it should be low. Iron is stored as ferritin. If there is iron deficiency, the first thing to occur is decreased ferritin level. After that, anemia starts to occur. But the first parameter to be affected in iron deficiency, it's decreased ferritin. So this is how to manage microcytic hypochromic anemia, which is more common to be iron deficiency anemia. So we will start talking about alpha-thalassemia, which is encoded by 4 genes on chromosome number 16. And we said that if the 4 genes are not present, this is incompatible with life. This baby will die as hydrops fetalis or very soon after delivery. And this is called hemoglobin parts. And you can identify hydrops fetalis of the fetus if hemoglobin parts is present. If the 4 genes are present, this is healthy person. If one gene only is affected, this is silent carrier. Silent means asymptomatic and needs no treatment. Loss of 2 genes, this is thalassemia minor. Loss of 3 genes, look, 1, 2, 3, it's hemoglobin H. So if 3 genes are affected, this is hemoglobin H. And in this situation, you will find that alpha subunits became low level. So beta chains will start to accumulate because there is no sufficient alpha subunits. Here, there is no alpha subunit because 4 genes are absent. And this is the most severe form. We said that thalassemia is autosomal recessive. We are now talking about alpha subunit. As you see, we should have 4 healthy genes. 1, 2, 3, 4. This gene marked by X is lost 1, absent gene. This male partner has 2 absent genes of the 4. And this woman has thalassemia. She is silent carrier, which is the first situation by absent 1 gene. Okay, what about the siblings? This chromosome may take this chromosome. So 2 genes also will be affected. We call this thalassemia minor, thalassemia trait. Okay, and this one may take this one. So we have now 3 genes affected, 1, 2, 3. It's hemoglobin H. And it may be this chromosome attaches to this chromosome, completely healthy person, complete healthy. And this chromosome may be attached to this chromosome, it's silent carrier. So this is the inheritance of thalassemia. It's autosomal recessive, and this is how its inheritance occurs. Again, if the 4 genes are present and the 4 subunits, the 4 genes are present, this is normal person. 1 gene is affected, this is silent carrier. 2 genes are affected, thalassemia trait. Either 2 genes on the same chromosome, or 1 on 1 chromosome and the other is on the other chromosome. Hemoglobin H, 1, 2, 3. 3 chromosomes are affected, and this is hemoglobin parts, which is incompatible with life, leading to hydrops fetalis. Okay, up till now, everybody is understanding? Any question in the previous slides? So this is silent carrier. This is 2 genes are affected, thalassemia trait. 3 genes are affected, hemoglobin H. 4 genes are affected, this is hemoglobin parts. We can make it like this. All the 4 genes are affected. Of course, incompatible with life and hydrops fetalis. Hemoglobin H, the condition is severe and repeated blood transfusion may be needed, and the condition may be very severe or less severe. So according to the severity, the frequency of blood transfusion is determined. Thalassemia trait, we have mild anemia, so less frequency of blood transfusion. While in silent carrier, it's apparently healthy and there is no need for blood transfusion, and even hemoglobin level is normal and there is no need to treat. That's why if we find that our female patient is searching for pregnancy and she is known to be thalassemia, so we have to screen her partner because her partner may be silent carrier or maybe thalassemia trait and he doesn't know that he has thalassemia. So we have to screen, and we can offer these couples to have IVF and BGD to choose healthy embryos which doesn't have thalassemia genes. Okay, if both of them are carriers, we can offer donor insemination by donor semen, or we can offer oocyte donation. This is the appearance of hydrops fetalis, which occurs with hemoglobin parts, in which the 4 genes are affected. And of course, this is incompatible with life, as you see. Beta-thalassemia. Beta, it's encoded by 2 genes on chromosome number 11. We have either 1 gene affected, we have either 2 genes affected, and 1 gene is affected, and the other is borderline. So we have intermediate picture. We have minor, major, and intermediate. According to hemoglobin level, we will determine whether this woman needs blood transfusion or not. This beta thalassemia, commonly in Mediterranean, Middle East, Asia, and Africa. Also, India, Pakistan, Bangladesh. And in Britain, there is Great London, Birmingham, and Manchester. These are the highest areas with prevalence of beta thalassemia. As we said, we have 3 forms, either minor, major, and intermediate. We call major beta thalassemia as Cooley's anemia. And as we said, if there is no alpha subunit, there is no life. If there is no beta subunit, there is a problem, of course, but the body can compensate to a certain degree by production of other subunits, like gamma subunit, which is present normally in the fetus. In UK, there is a screening program for thalassemia. They search for thalassemia in all neonates because they may be carriers, and many children are classified as thalassemic babies after the screening of neonates. As we said, beta thalassemia, 2 genes on chromosome number 11. It may be minor, major, which is Cooley's anemia, or intermediate. So we have minor, intermediate, and major. Minor, always the condition is mild. You may need blood transfusion or not. And the body can compensate by production of hemoglobin A type 2. We said that we have 2 types of adult hemoglobin, 1 and 2. 1 contains 2 alpha and 2 beta. Adult type 2 contains 2 alpha and 2 delta. So the body can compensate. If there is problem in beta subunits, we can produce gamma subunits to form higher concentration of adult hemoglobin type 2. Thalassemia intermediate, one gene is affected and the other is partially affected, so it has many clinical pictures according to the severity. This patient needs transfusion or not, and they may need less frequency of transfusion per year. The severest form is beta-thalassemia major, complete absence of the 2 genes. So malformed RBCs will be formed and they will be destructed after short duration in the circulation. So we have hemolysis, extramedullary hematopoiesis, so we will have hepatosplenomegaly. The patient has all symptoms of anemia, and due to the destruction of these RBCs, there is increased risk of thrombosis, bone deformity because of medullary hematopoiesis, pulmonary hypertension, congestive heart failure, and blood transfusion is needed. This is a clinical picture of beta-thalassemia major, in which the 2 genes are absent. Don't forget that thalassemia, we said that thalassemia is a risk factor for thromboembolism. What is the score of thalassemia as a risk factor? Thalassemia takes score 2. So we need at least 10 days postpartum. At least 10 days. And we will know now that we will give 10 days if delivered vaginally. And we will give for 6 weeks if delivered by cesarean section. Because thalassemia, it takes score 2. Elective cesarean section, it takes score 1. So we have score 3, which means 6 weeks postpartum. So thalassemia itself, it's a risk factor for thrombosis. Okay, 1 second. Okay, how to diagnose thalassemia? As we said, it's microcytic hypochromic anemia, and it's the second one in the differential diagnosis of microcytic hypochromic after iron deficiency anemia. In relation to the days of postpartum prophylaxis, thromboprophylaxis, you will find that there are differences between the guideline of venous thromboembolism and thromboprophylaxis and the guideline for sickle cell disease and thalassemia. We will say what is present here and what is present here. Okay? Don't discuss. I will tell you what is present here, and we received already, we knew already what is present there. So we have hemoglobin, maybe normal, yes, because we have silent carriers. It may be mild reduced if there is thalassemia trait or thalassemia minor. As you see, mean corpuscular volume is decreased. That's why it's microcytic anemia. Reticulocytosis. Reticulocytes are the precursors of RBCs. If there is hemolytic anemia, the bone marrow and extramedullary organs will try to compensate by increasing the erythropoiesis. So we will have large number of reticulocytes inside the blood. If you do hemoglobin electrophoresis, you will identify is it alpha-thalassemia or beta-thalassemia, and you can do what's called high performance liquid chromatography. It's this equipment which identifies the nature of hemoglobin. It's advanced technique. Okay, we have here adult hemoglobin, fetal hemoglobin, adult type 2, sickle hemoglobin, and others. In normal person, most of the body contains hemoglobin adult type 1. Less than 5% adult type 2. About 1% fetal hemoglobin. Beta-thalassemia trait. In beta-thalassemia, there is a problem in beta subunit. So the body can compensate by using other subunits like delta and gamma. In beta-thalassemia trait, there will be increase in delta subunit. In beta-thalassemia intermediate, there will be increase in gamma subunits. So fetal hemoglobin will be increased. Cases with beta-thalassemia major, as you see here, most of the blood contains fetal hemoglobin. Okay, thalassemia trait. The presentation of thalassemia trait, it's different severities of the degree of anemia according to the level of genetic affection. So we have to identify the severity, and we have to identify the hemoglobin level, and of course, to diagnose that this is thalassemia, we did already serum ferritin level, and we find that serum ferritin is normal in thalassemia. That's how we differentiate between iron deficiency anemia and non-iron deficiency anemia. So please, in cases with thalassemia and sickle cell, don't give iron. She is already intoxicated with iron. But we can give folic acid. Folic acid is important for erythropoiesis, and it has no toxicity in hemoglobinopathies. And we have to give even high dose of folic acid. We have to give 5 milligram. 5 milligram. The usual dose is 400 microgram. But cases with hemoglobinopathy, we give high dose, which is 5 milligram, and don't give iron. Okay, in beta thalassemia, we know that there is minor, there is major, which is Cooley's anemia, and there is intermediate. Beta thalassemia trait, it's mild affection, there is no problem, you may offer no treatment. Thalassemia major, the condition is severe. We will give folic acid, don't give iron, and blood transfusion to compensate the anemia. In the past, they used to do splenectomy as a measure in treating any hemoglobinopathy and hemolytic anemia. This now has decreased. We rarely need splenectomy now to solve this problem because splenectomy, it's a dangerous maneuver. It has complications like increasing the risk of infection by pneumococci, Neisseria, gonorrhea, Neisseria meningitis, and Haemophilus influenza. So it's a dangerous maneuver. It has complications, but patients with splenectomy, they were found to have better hemoglobin level, less blood transfusion. Another measure needed, as we said, these women or these patients has already iron overload. So we need to give iron chelators. This iron is deposited in many organs, causing dysfunction in many organs. So it's important to give iron chelators. And even if you have thalassemia patient searching for pregnancy, before pregnancy, offer her intensive chelation of iron. Because we don't prefer to give iron chelators during pregnancy. And if we have to give, we start to give at pregnancy after 24 weeks, not earlier than this. But sometimes we have difficult situations of cardiomyopathy. Iron is deposited in the heart and may lead to heart failure if not treated. We can give iron chelators after 24 weeks. Even these iron chelators, they have side effects, especially with lactation. You know, they are expressed in lactation, but there is very important point that this ferrioxamine, it's expressed in breast milk, but it's not absorbed by the fetal intestinal tract. We give this iron chelator, this ferrioxamine, it's the recommended one to be used during pregnancy, not difeprinone, we don't use it during pregnancy. This ferrioxamine, it's expressed in the breast milk, but not absorbed by the fetal GIT. So no problems at all. If the woman is practicing breast milk lactation while she is receiving this ferrioxamine, there is no problem at all. What about cases with splenectomy? As we said, its role is regressing with time because it has complications like increasing the risk of gonococci, pneumococci, and Haemophilus influenza type 2. So if a woman had splenectomy, we have to give antibiotic prophylaxis against these infections. We can give penicillin or erythromycin to protect against pneumococci and Neisseria. Also, Haemophilus influenza vaccine should be given, meningococcal vaccine, and pneumococcal vaccine. They should be given to protect against gonococci, pneumococci, and Haemophilus influenza. Because spleen is very important in protecting the body against encapsulated organisms like Neisseria, gonorrhea, and Neisseria, not Neisseria, against pneumococci and gonococci. Blood transfusion is the most important method for treatment. The woman has anemia and she has hemolysis. We can give her blood transfusion. It's the most important point for management. Our target is to always keep her hemoglobin above and more than 10 gram per deciliter. So more than 100 gram per liter. Iron chelators, because iron is toxic. It's deposited in many organs, causing diabetes, hypothyroidism, infertility, if precipitated in the pituitary. Can you tell me if iron is deposited inside the pituitary gland, causing malfunctioning anterior pituitary? And this woman is searching for fertility and she has amenorrhea because no FSH and LH are produced. Can you tell me, can we treat her? Number A, by gonadotrophins. Number B, GnRH analog. Number C, by clomiphene citrate. Can you tell me which line is suitable? You can write the answer on the screen. Choose A, B, C. You can write on the screen directly, not on the chat. Okay, A is the answer, you are right. Because if you give clomiphene citrate, the anterior pituitary is non-functioning. So it's not helpful to give clomiphene citrate. You have to give gonadotrophins directly. She is suffering of decreased gonadotrophins, give gonadotrophins. When this iron is precipitated in the heart, it can lead to heart failure. A common question in the exam, what is the commonest cause of death in thalassemia? The answer is heart failure. Dr. Sadia?
Yes, sir.
Can you tell me what is the commonest cause of maternal mortality in UK?
It's due to thromboembolism, pulmonary embolism.
Thromboembolism, it is the commonest direct cause of this. Direct cause of this.
Yes, sir.
While the commonest cause of maternal mortality in UK, it's indirect cause. And the most important indirect cause is cardiac disease. You know the last maternal mortality report, the Brasi report? It was published December 2017. The maternal mortality rate was 8.5 per 100,000. These 8.5 mortalities, 2 of them are cardiac diseases. So cardiac disease is the commonest cause of death. So if I told you, what is the commonest cause of maternal mortality in UK?
It's due to cardiac disease.
Cardiac, thank you. What is the commonest indirect cause of death in UK? In maternal mortality. Indirect.
Indirect is cardiac cause.
Cardiac, thank you. What is the commonest direct cause of death?
Thromboembolism.
Thromboembolism, thank you.
Thank you.
These are very important questions. And as you saw, about 25% of mortalities are due to cardiac. So we have now Dr. Nagla.
Yes.
Please, can you tell me what is the cause of death in preeclampsia?
Preeclampsia?
Yes. You attend preeclampsia with me?
Yes.
Can you tell me why women with preeclampsia die? What is the commonest cause of death in preeclampsia? Intracranial
Hemorrhage?
hemorrhage. You are right. It's intracranial hemorrhage, followed by liver affection of preeclampsia. So the first cause of death in preeclampsia, it's intracranial hemorrhage. The second one is hepatic affection of preeclampsia. These are some collections of causes of mortality. Okay, thanks. Thanks for you.
Okay, thank you, doctor.
Thank you. So here in thalassemia, women die because of precipitation in the iron inside the cardiac muscle. You saw now how this iron intoxication is fatal. That's why it's important to search for what is the concentration of iron in the heart and what is the concentration of iron also in the liver. It's called Ferri scan. Ferri scan. By assessing amount of iron inside these organs. We use MRI as non-invasive technique to assess iron level inside the heart and iron level inside the liver. This is the Ferri scan. It's MRI to assess the level of iron by in the liver and in the heart. As you see, there is a computer program which tell you how much iron is present inside the liver and how much iron is present inside the heart. Of course, iron in the heart is more dangerous. It's called Ferri scan. So we use MRI T2. There is MRI T1. We don't use it. We use MRI T2 for assessment of iron inside the liver and inside the heart. Okay, as we said, this iron is deposited inside different body organs. The most important ones are the heart, which is the commonest cause of this in thalassemia, and also in the liver. It can lead to cardiomyopathy. If we leave this woman without iron chelation for 9 months, she will develop diabetes, hypothyroidism, hypoparathyroidism due to iron toxicity. So why we say 9 months? It's the duration of pregnancy. That's why if a woman with thalassemia is searching for pregnancy, we need intensive chelation before pregnancy. And if there is increased iron load in the liver or in the heart, we can offer iron chelation in the late 2nd trimester. Who will take care for this woman? It's MDT. MDT, so internal medicine with hematology, with obstetrician, nurse also interested in thalassemia, so it's MDT. And we have to search for end organ damage, especially heart, liver, thyroid, pancreas. If there is complications, we have to manage, like diabetes, for example, or cardiomyopathy. Iron chelation is needed, especially we can do intensive iron chelation before pregnancy. Sometimes you will tell the woman, we are sorry, you have severe iron intoxication and you have diabetes and your cardiac function is not doing well. Please, we want to delay this pregnancy until trying to control these risk factors. And if a woman is anovulatory with thalassemia, this anovulation is caused by decreased gonadotrophins due to precipitation of iron in anterior pituitary. How to treat gonadotrophins? In the heart, we will use the Ferri scan, MRI T2. We need T2 to be more than 20 milliseconds. This is our target. If you do Ferri scan, MRI T2, and you find that the result of MRI T2 in the heart is more than 20 milliseconds, this is normal. This is good, accepted, it's our target. If MRI T2 is less than 10 milliseconds, this is high risk and heart failure may occur. Between 10 and 20, it's borderline. So our target to keep MRI T2 for the heart more than 20 milliseconds. Less than 10, impending heart failure. Between 10 and 20, it's borderline. Okay, how to manage myocardial iron? As we said, we can offer iron chelation, desferrioxamine, after 24 weeks of pregnancy. What is the dose? 20 milligram per kg per day. How to give? Subcutaneous. And this dose is very important. We have to memorize 20 milligram per kg per day, starting at 24 weeks gestational age. How to give? Subcutaneous. It's not given oral. It's not effective oral. And we have to monitor for the cardiac complications. We have to monitor for ejection fraction. Okay, somebody knows what ejection fraction means? What means ejection fraction?
एक बार डॉक्टर के जाने के बाद में कुछ ना पूछ लो नकल रोड कहाँ है, वो वहाँ पर सीधे जाके आंध्रा ब्रेन एंड हार्ट और ब्रेन दोनों भी एक ही हॉस्पिटल में देख सकते हो। वो आंध्रा हार्ट ब्रेन फिर
okay. Ejection fraction, we say that if we imagine that the heart received 100 milliliter blood at relaxation during diastole, after systole, what amount of these 100 milliliter was pumped? If the heart pumped, for example, 60 milli, so ejection fraction is 60%. If the heart pumped 40 milli, it's 40%. This is ejection fraction, and it's a good measure to assess the function of the heart. So we need to assess ejection fraction during pregnancy. Diabetes, as we said, we will not do follow-up for this diabetes by hemoglobin A1C because she is receiving blood transfusion, so it's not here on hemoglobin. So we use fructosamine, and we need fructosamine to be less than 300 nanomole per liter. It's a question in the exam. What is the needed level of fructosamine in diabetes with thalassemia? I need fructosamine less than 300 nanomole. Okay, this is equivalent for hemoglobin A1C 43. Okay, somebody knows what is the target level for hemoglobin A1C? If a diabetic woman, she doesn't have hemoglobinopathy, she is only diabetic, and she is searching for pregnancy, what is the required level of hemoglobin A1C before delivery? You can write on the screen. What level of hemoglobin A1C do you want for a diabetic woman searching for pregnancy? Thank you. It's less than 6.5. Less than 6.5. This is a normal level. Less than 6.5. And if the level of hemoglobin A1C is 10 or more, advise her against pregnancy because we have very high risk of teratogenicity. If hemoglobin A1C is 10 or more, advise her against pregnancy. So we don't use hemoglobin A1C. Thyroid function, iron is deposited in thyroid gland leading to hypothyroidism, and it can increase the maternal morbidity, perinatal morbidity, and mortality. Because even the fetus inside the utero during the first trimester needs the mother to be euthyroid. We say that during the first trimester, the fetus needs ready-made T3 and T4 from the mother. While after the first trimester, the fetus doesn't need maternal T3 and T4 because its thyroid gland now is able to manufacture its own T3 and T4. Just the baby needs. iodine from the mother. Iodine. While there is no need for T3 and T4 of the mother after the first trimester. So during the first trimester, the embryo needs ready-made thyroid hormones. After the first trimester, the fetus needs only iodine. Even if the mother tried to give T3 and T4 to the fetus, after the first trimester, the fetus will not accept, and thyroid hormones will be destroyed by the placenta. Liver, it's very important to assess amount of hepatic iron. We need hepatic iron to be less than 7 milligram liver, less than 7 milligram. Very important number. Okay, so we need MRI T2 to be more than 20 milliseconds. And if less than 10 milliseconds, this may lead to heart failure. And between 10 and 20, it's borderline. Here in liver, we want iron to be less than 7 milligram. If higher than this, again, we can offer chelation at 20-24 weeks by desferrioxamine, 20 milligram per kg subcutaneous. Bone density. Why bone is affected? Because of iron chelators. Iron chelators takes excess iron to be excreted and also takes calcium. That's why they may suffer from bone pain and osteoporosis because of iron chelators. Also, in thalassemia, there is hyperactive bone marrow. This decreases the bone mineralization. Also, pituitary malfunction will lead to decreasing gonadotrophins and decreasing estrogen. This leads to osteoporosis and vitamin D deficiency. So we need to assess vitamin D before pregnancy because vitamin D activation needs the skin to manufacture dihydroxycholecalciferol, needs the liver to form 25-hydroxycholecalciferol, and needs the kidney to be 1 and 25 dihydroxycholecalciferol. There may be impairment in the liver or renal impairment due to iron deposition, so vitamin D deficiency also may occur. So we need to offer bone mineral density. To assess bone mineral density, we use what's called DEXA scan. And when we use DEXA scan, we have two measures. We have two methods to assess DEXA scan interpretation of the results. We have either what's called T-score and we have Z-score. What's more commonly used, it's Z-score. Another problem in patients with thalassemia, it's increased occurrence of red cell antibodies. You know, the RBCs has antigens like ABO antigen, RH antigen, D capital, E capital, C capital, C small, KIL, and others, many antigens. Red cell antibodies are expressed more in patients with thalassemia. That's why there is difficulty in giving her the optimum blood transfusion and the optimum blood group. That's why we have to do detailed cross-matching and detailed identification of the specific blood group for these women. And it's a challenge to offer blood transfusion to them by giving the specific blood group to avoid sensitization. What iron chelators do we use? We use Differential. It's the best one during pregnancy. We can use it starting at 20 weeks, and the dose also 20 milligram per kg per day. We can offer this Differential subcutaneous 4 days per week. So we can give today, tomorrow, after tomorrow, 4 to 5 days per week until reaching the target level of MRIT2 of the heart and of the liver. Another advantage of Differential, the first advantage, it can be used during pregnancy. Another advantage, it can be used during breastfeeding because it's not absorbed by the neonatal GIT mucosa. Also, another advantage, it has short duration. How this is useful? If your case is anovulatory due to decreased gonadotrophins, which is caused by disorder in the pituitary due to iron deposition, and you are going to give her induction of ovulation, you can give induction in the same time you are still using this Differential. It will not affect pregnancy because it has short duration of action, short half-life. So teratogenicity will not occur. This is Differential. This is Differzarox. This is Difeprinone. We don't use Difeprinone. We don't use Differzarox with pregnancy. We use Differential. As you see, it's injection form. We use 20 milligram per kg per day. We can start at 20-24 weeks if hepatic iron or cardiac iron are increased. Vaccinations, they are important if patients with splenectomy against gonococci, pneumococci, Haemophilus influenza. Also, these patients are receiving repeated blood transfusion, so they are at risk of having hepatitis. So if she didn't receive before hepatitis B vaccine, offer hepatitis B vaccine and check that antibody status became positive after the vaccine, so we know now that the vaccine is effective. Of course, there is no vaccine for hepatitis C up till now. Folic acid, we give 5 milligram, while the usual dose in a non-thalassemic patient is 400 microgram per day. And it's now recommended to give folic acid 400 microgram per day for any woman searching for pregnancy. We prefer to give it 3 months before pregnancy and also during the first trimester after being pregnant. While in cases with hemoglobinopathy, we give 5 milligram throughout all pregnancy because she has active erythropoiesis. So we need large doses of folic acid for erythropoiesis and for prevention of open neural tube defect. Don't forget, as we said, if you have a patient or even a carrier with thalassemia searching for pregnancy, check the status of her partner and offer them IVF or ICSI with BGT to select the embryos which doesn't have thalassemia. If the patient is diabetic, there will be MDT between diabetologist, endocrinologist, hematologist, and obstetrician. And if this woman searching for pregnancy, as we said, we will give her iron chelators. She is not pregnant up till now, so we can give Differential or Differzarox. While if we are giving induction of ovulation, we can give this ferrioxamine. Don't forget folic acid. Splenectomy needs antibiotics and vaccination. Also, we will do MRI to the liver and to the heart. If iron is increased, we will offer aggressive chelation. And we can involve cardiologist and the diabetologist to assess liver function and hepatic function. Don't forget increased risk of red cell antibodies. That's why it needs more details to select the most appropriate blood transfusion, document blood pressure, midstream urine, confirm early viability by ultrasound early in pregnancy. Because, as you see, thalassemia, it's associated with complications, maternal and fetal. Okay, we will take 5 minutes break. 5 minutes break.